Okay, we're going to start soon. Now, I'm not going to give a lecture, and I tend to walk to the back and ask questions of people at the back, so I'd suggest you move to the front, because this should be an interactive workshop. And normally at these courses we have patients here. For some reason there are no patients, because I do hands-on teaching. I don't want that light on my face, thank you. So this is an informal time for discussion, and how many people here look after patients with diabetic foot problems? Everybody? Yeah, everybody? Okay. So are you a pediatrician? Are you a pediatrician? So you don't see any diabetic foot problems?
I deal with foot problem, but I'm not specialized in this.
Okay. Don't worry, nor am I. I'm just a clinical diabetologist. So what I'm going to do first, I have some slides, but these workshops should be interactive. So there were no chance for discussion after the talk because we were running late. So does anybody have any questions you want to ask on the diabetic foot? This would be a good time. Well, a workshop should be interactive, not me giving a lecture. So if you want to ask anything about my lecture this afternoon, either one.
What the novel shoe to the offloading of the diabetic foot?
Okay, you want to hear something about offloading?
Yes.
Okay, right. Anybody else interested in offloading? Because that's the key to treating diabetic foot ulcers. I've got some slides I can show on that. Offloading, because I didn't have time to cover it in my lecture.
The second small question, the use of the hyperbaric oxygen in the diabetic foot.
Hyperbaric oxygen, I dealt with that. I don't think there's any use for it. I think there is no evidence base. It's expensive. It's used, it's reimbursed, and people make a lot of money in the United States from hyperbaric oxygen. But I tried to show you that the evidence is minimal, that it's helpful. Yeah. Can someone take the microphone around? One of you guys?
Hello, Peter. I want to just ask about the how to assess the gait, and what do you do if you found someone that he's having a problem with his gait? What's the...
Okay, so the question is how to assess gait. Now, for clinical practice, I don't do any foot pressure studies. That's helped us inform us the causation of foot problems and help us in research. We are doing studies in patients because patients with neuropathy have a very pronounced large fiber. I trained in neurology too, so apologies for talking in different size fibers, but large fibers carry joint position sensation and vibration. Diabetic neuropathic patients, even though it's not in the older textbooks, have marked unsteadiness. So they're unsteady, especially with eyes closed. They're unsteady in the dark, and this probably leads to trips and falls that precipitate Charcot foot. We're doing some studies now with exercise training, trying to strengthen muscle strength and to help people with unsteadiness in diabetes. And what we've shown is that people, as I showed in that movie, are unsteady mediolaterally and anterior posteriorly. Now, previous exercise training for muscles of these patients has worked on the flexors and the extensors. But what we've showed, you also need to work on the abductors and adductors. So we're doing some more studies looking at that to see if... I can't take that light, I'm sorry. I don't want that light on. Thank you. So to see if people benefit from exercise training, not only anterior, posterior, but lateral and medial. So we're working on that now, and it may be, there is some evidence that exercise training may help people with this marked unsteadiness. Microphone.
I would like to give some information about our work in dispensary in Saudi Arabia. We have form filled annually by doctor. This form categorizes the patient for the diabetes patient, 3 categories: low risk, high risk, low risk, moderate risk, high risk.
It's like traffic lights. Green is normal, amber or yellow is need instruction, red is very high risk.
Yeah.
That's many people use that, and it's been shown to be helpful in Scotland, for example. Yeah.
But the main dilemma for us, the main problem, how to choose a shoe for the diabetes.
Well, I would say with respect to footwear, first of all, if you've got neuropathy, patients will always, if they're left to their own devices, they will always buy a shoe that is too small. That's because with sensory neuropathy, you lose the pressure sensation, so you need more pressure to feel that the shoe is fitting. So they will always buy shoes too small that will lead to problems. Most patients with normal shaped foot just need sensible shoes. And I never look at women, but you know, a wide toe box, plenty of depth, and the sensible trainers are quite good. If you call them trainers here, or sneakers in America, some of those are very good. So you need a good shoe that fits the foot. And what I tell patients to do is stand on a piece of paper and just cut round the edge of the foot, and you've got a piece of paper that matches the shape, and to see if the size is right. And patients will buy shoes that are too small because they need more pressure to stimulate the perception of fit. So that's the thing to be aware of. Now, those with Charcot feet often need custom molded shoes, which are more expensive, but they're made specially by the orthotist to fit the misshapen foot. So most patients with diabetic neuropathy don't need special shoes, they need sensible shoes.
I always thought that if you start with an offloading need that would not be fulfilled, that you will eventually end up with Charcot through the repetitive.
That's a good
exposure.
question. A good question, but we don't know why it is that if you take 10 patients with a severe sensory loss, why is it that only one gets a Charcot foot and the other 9 do not?
I didn't assume it's a knowledge. I'm asking you for your expertise.
Yeah, well, no, I don't know the answer to that question. So it's some kind of repetitive minor trauma that leads to sprains, that then you get increased inflammation, which is normally relieved if you limp and don't put pressure on that foot, and that leads to collapse of the bones.
I read about a new footwear that would use gel and some sort of synthetic material.
Yeah, we're looking at that right now. We have a study going on looking at different sensors in the shoe. And these sensors feed back to a wristwatch and warn the patient if the pressure is too high at one spot. Another way is to have temperature sensors. And I was at the Diabetic Foot Conference earlier this year, where the company is using special socks that have sensors for pressure and temperature. Auto feedback, yeah. So that is a very interesting area of development at the moment. Yeah, well there are special socks being studied right now in the United States that will warn the patient if one foot is warmer than the other. And there's another study that's just published by Bob Freiberg in Diabetes Care that uses a bath mat, and each morning while you're shaving or washing, you stand on this and it compares the foot temperature of both feet. And they've shown in a publication that this will help predict ulcers. So if one foot is warmer, they've shown that ulceration is more common. Yeah, so you've got a unit, that's good. Yeah. So if you want, and people interested, yeah.
Yes, what is your opinion about early discovery of peripheral neuritis in diabetic by examining the cornea?
Well, we started that, yes.
Yeah.
Yeah, it was in Manchester in 1999. A patient of mine was professor of optometry, and he was fine. So we discussed, how can you envisage peripheral nerve in vivo without an invasive technique? Because the only way, at the retina, we can look. You can look at the retinal photograph and you can see retinopathy. Urine, you can look at urine, and that's a marker of nephropathy, but there was no such marker for neuropathy. So this guy said, well, we're looking at the corneal nerve fibers, and we've got a corneal confocal microscope. So I went down to have a look, and there are very similar nerves to peripheral nerves, nerve roots and so on. So we put a project together, said perhaps the changes in the corneal microscope picture of peripheral nerve will mirror the changes in the lower limb. So I said to then my research fellow, what we need to do, and my research fellow, you may know, Professor Riaz Malik, yeah, and he did his PhD with me, and I said, Riaz, this could make your career. Let's do a study, let's look at 5 groups of patients, non-diabetics, diabetics no neuropathy, diabetics mild, moderate, severe neuropathy. Let's take the corneal confocal microscopy. Let's look at nerve fiber length and density and see if they match the measures of peripheral neuropathy we use to identify the high-risk foot. And we did that, and it did. And we went on to do many more studies, and we have, I was just saying to some people I was discussing yesterday, I was in my clinic, the Big Diabetes Renal Clinic in Manchester. I saw 3 patients who were doing well 15 years after simultaneous pancreas kidney transplants. So we followed these people who had severe neuropathy, and we've been able to show improvement in small nerve fiber measures in the cornea after normalization of blood sugars after a pancreas transplantation. So this could be a very useful surrogate marker, and it's being used widely now, and there are big conferences about it. So that's what we started back in 1999. The first study was done 2000, 2001, was published in Dermatologia in 2003. So this is a useful surrogate marker, but I think it's going to be used for research to help us assess new treatments, because you can do multiple reiterative, repetitive studies of the cornea, and there's no biopsy, no skin biopsy, no nerve biopsy, it's just a photograph. So this is a good way of looking at peripheral nerve and seeing the changes that have occurred. Now, someone said, I'll go and put a few slides. Any more questions while I'm getting a few slides ready? Any questions? Fire away, because I've got to find this paper. Where do we put it? Oh, there we are. Okay. Right, I'll put a few slides together. You asked about offloading. Okay, can we put this talk up now? It's on this screen. Can we put it on the main screen? Can we put the slides that I've got here onto the main? Yes, you can. Good. So this is, you've asked about offloading the evidence. So this is a talk I gave the Royal Society of Medicine just earlier this month. So I mentioned before that neuropathy is a major cause of diabetic foot ulcers. But when I went to Manchester, there wasn't actually any evidence. We all knew that diabetic foot ulcers occur in patients with neuropathy, but there was no prospective study. So we started a study back in 1988, where we followed a group of patients you see here for a good number of years, 5 years. We assessed their vibration by using the biaesthesiometer, and we saw who got foot ulcers. Have you seen this is the biaesthesiometer? Are you familiar with this? This is a vibrating stylus here, and the measure here, that's the measures here from 0 to 50, and this vibrates, and the patient says when they can first feel it. And there's a scale of 0 to 50. The higher the reading, the more severe the sensory loss to large fiber function. And what we showed in this study, if you look just at the bottom line, the risk per patient per year, if your vibration perception threshold is normal, that's less than 15, your risk of getting a foot ulcer per year, this is not a very good pointer, but it's the only one I've got, is 0.7%. If you've got neuropathy, your risk is 7 times higher, or 1 in 20, 5%. So that was the first study that showed this. And this is a study we did joint with University of Seattle with Gail Reiber, where we looked at the causal pathways to foot ulcers, and we showed that neuropathy was present in 4 out of 5 ulcers. And the commonest combination was neuropathy, deformity, often clawing of the toes, prominent metatarsal heads due to neuropathy, and trauma. And the commonest trauma in our country is, what do you think the commonest trauma is? Huh? Footwear. Yes, footwear. Inappropriate shoes is the commonest cause. Inappropriate shoes. So it's inappropriate shoes, pressure, repetitive stress, and breakdown. So that's the pathway to ulcers. Neuropathy, deformity, trauma, and some leads to an ulcer. It's difficult to draw a shoe too small. It's easier to draw a nail. That's I've showed you already. And we've proven the use of a semi-quantitative way of foot pressure assessments called PodaTrack or pressure stat, which we've validated. And this is the pressure stat. You just walk across this sheet. The darker the area, you see here in the fifth metatarsal head and the hallux, pressure's quite high there. The darker the area, the higher the pressure. So you can give this to the patient and say, look, pin this up in your bathroom. When you check your feet, dark equals dangerous, especially be checking the big toe and the metatarsal head areas. So this is a very simple technique that measures pressures in one footstep and will identify the highest pressure area that the patient may be able to screen. Now I showed you this, and we're not so good at offloading pressure. So it's what you take off the wound that matters more than what you put on it. So you take off pressure, but also callus, debridement. The neuropathic foot ulcer is caused because of autonomic neuropathy, dry skin, repetitive stress, build-up of hard skin that becomes like a foreign body, like a stone, and it digs into the foot and causes an ulcer. So you take pressure off the wound by offloading it, and you take the pressure from callus. So you debride the wound, debride the whole area, and that may actually release endogenous growth factors from the patient themselves. So if you put a neuropathic patient with a foot ulcer to bed, they think the next morning, they think, fantastic, my foot feels wonderful. But of course they never felt any pain anyway. So up they get and walk away. If we give patients crutches, my head nurse, she's got a pair of binoculars and watches patients leaving the clinic. And they'll walk out with the crutches that they've not used because they've got no feedback to tell them something's wrong. So the total contact cast is the gold standard, but the removable casts are often used. Now the total contact cast, like a Bologna orthopedic cast, has its advantages. It's difficult to remove. You can move, you can walk, but it reduces activity because it's a nuisance. So these patients, it doesn't remove pressure, it redistributes it elsewhere, and it reduces markedly the pressure over the ulcer area. And this is one study of David Armstrong, you may have heard of, you may have met him. He was a PhD student of mine in Manchester. He's from the United States. And part of his PhD with this randomized controlled trial, where he randomized patients to a half shoe in green, a removable cast walker in red, and the irremovable cast, total contact cast in blue. And you see at every stage of follow-up, there's more rapid, more healing in the total contact cast group. Now you may ask, why should that be? Because we've shown in the Gate laboratory, if you put sensors inside on the foot in a cast, then the reduction of pressure is similar in the removable cast walker and the total contact cast. So why should this be? Now Alberto Piaggesi in Pisa did a study where he showed that patients who walk on their ulcers, it maintains chronicity of the ulcer. So what they do in Pisa with a neuropathic ulcer, they chop it away, ulcerectomy. So what he did, he took two groups of patients, they were all presenting with new foot ulcers. One group he did the ulcerectomy that day, the other group had a total contact cast for 3 weeks, and then the ulcerectomy. And they compared the histology. And what it showed is that those on the left with the total contact cast had more capillaries, more granulation. On the right, you see there's very little granulation and there's fibrosis and hyperkeratosis and inflammation. So walking on an ulcer maintains its chronicity. You see here, that's when you're walking on an ulcer, you've got a huge infiltrate, you've got the breakdown. On the right, if you wear the offloading device, because you can't take it off, you've got a lot of an infiltration there of healing cells, neutrophils, and at the bottom you've got new glands forming. So if you walk on an ulcer, it makes it chronic and it stops healing, what he showed. If you offload the ulcer, then you get capillary infiltration, granulation tissue. So pressure not only has a direct effect on the ulcer, but also supports the chronic inflammation. after pressure relief, the foot ulcer in many ways becomes like an acute wound, so it heals up. So prolonged repetitive pressure is what keeps ulcers chronic. And of course they may become infected, you may get osteomyelitis, localized gangrene, and end up losing the leg. So why are removable devices not good? Well, they are good if they're worn, that's the answer. So what we published in 1996, in the National Health Service, we provide our patients with free footwear if needed. And even if we provide these patients with footwear that's specially molded for their feet, they only wear it 20% of the time. That's what they told us. We know that the DH walker or the air cast offloads as well as the total contact cast. But what we did with David Armstrong in the United States and published about 15 years ago, we took groups of patients with active neuropathic foot ulcers. We gave them all a removable cast walker and said, every time your foot hits the ground, inside or outside, you must wear this cast. But we would know, we told patients we would know if they were wearing it or not. And what we did inside the cast walker was an activity monitor that was hidden. And then the patients wore an activity monitor around their waist all the time. And if the boot was more than 50 centimeters away, that would flag up activity without using the boot. And what we showed was only 28% of all footsteps were taken with the device on. Only 1 in 4 footsteps. So patients, removable cast walker, the key word is removable. And my head nurse watches patients going out, they'll take their cast, and then as soon as they're out of the clinic, they'll change their cast and get their shoes on. So they're not offloading. They're not fooling us, they're fooling themselves. So then in Miami, we did another study where we said, right, let's show that the removable cast walker, if used properly, works. So we took the removable cast walker and rendered it irremovable. So around the Velcro straps, we put a bit of Scotch cast so the patient could not remove it. It became a irremovable cast. And we showed, this is the standard total contact cast. Here's the removable cast walker, a DH walker. Then we made it irremovable by wrapping it with Scotch cast. And it just goes to show, if you wear the removable cast walker, it's just as good. It works very well. So removable cast walkers rendered irremovable are good at offloading the foot. They're less expensive because you use the same cast throughout. You don't need a plaster technician. Even I can put a wrap of Scotch cast around it. They're less time consuming and there's no more risk of complications. So that's good. So we believe there's time for a need for change of design of studies used in the diabetic foot. Because trials have failed because people are not offloaded properly. It doesn't give the new product a chance to show it's good. So that's what we should be doing. New trials should attend to standardized offloading across all groups. That's what we believe. And the systematic review here between 1966 and 2012 showed that non-removable devices are superior to removable. And the instant total contact cast, which is the walker rendered irremovable, is equal to total contact cast. So non-removable devices are superior to removable ones and therapeutic shoes. And there is evidence. So this is evidence-based practice. So I'm just thinking what other... I've got 2 other lectures here which might be of interest to you. Where would that be on here, gentlemen? The 2 lectures I put on, where are they? No. Because you did have a different... what other topics did you want to talk about? Oh, that's it. Session, workshop. Andrew Boulton there.
Second one.
So do you want to... I can show you some... Yes. Can you give him a microphone? Question.
The cellulites that you have in the foot.
Sorry?
Cellulites.
Yeah.
Plug in.
What about it?
When it comes with a ulcer.
If you've got cellulitis, in the foot with an ulcer, then this suggests a more serious infection. Always get an x-ray of the foot, and the plain x-ray is still extremely useful. We use it repetitively. The radiation risk of a plain x-ray is nil. And if, remember, changes occur slowly, we re-x-ray the foot, we debride the wound, we give, it depends on the degree of the infection. If there's very severe infection, we'll give intravenous antibiotics, but I cannot prove to you that IV are any better than oral, because nobody's shown that.
I'm speaking about sensory when you have the cellulitis,
Yeah.
you have an ulcer,
Yeah.
it's hiding,
Yeah.
and you want to do the cast, what you...
Oh, in a cast, okay. What we would do, if you've got a marked infected foot ulcer, offloading is very important because patients walk on the foot ulcer and it pumps infection through the multiple tissue spaces in the foot. And also you may get ascending lymphangitis. So we tend to give a removable cast walker plus antibiotics for the first week because there are dangers of casting a grossly infected wound. You may get edema, you may get pressure, and casts themselves can cause ulcer. So you need to be very careful. So we would give antibiotics plus a removable cast walker, telling the patient to inspect the wound and the leg every day. If it's improved the next week, then we may put them in an irremovable cast walker, but you need to remove it regularly because the cast itself can cause damage without the patient perceiving it. So our practice is if we use a irremovable cast walker, we bring them back in a week, remove it, check, bring them back in another week, remove it. If it's healing, it's doing well, then we'd leave it 2 weeks. But you have to remove them regularly, and if the patient has any sense of anything wrong, even if it's very minor pain, that is a sign to remove the cast and check, because these patients don't have normal sensation.
So I want to ring a bell because bleach will worsen in the case of the arm. The cellulitis will worsen in the case of the arm, the leg and back.
No, not necessarily. If you've got cellulitis, that needs treatment by antibiotics. We're presuming this is a neuropathic foot ulcer with good circulation. You can still cast, but removable cast walker, so you can check each day to ensure that there is progress in the resolution of the cellulitis, which would normally respond to the antibiotics. That usually resolves relatively fast. The ulcer takes much longer. Then you can use the regular offloading after that. That's what we do. Now, I've got a talk here on the... I don't think necessarily you want that one. What was the other one? Some unusual foot cases, if you're interested. Different presentations. So let me show you an atypical foot ulcer. This is a patient that came to my clinic. He was of Pakistani origin, 27 years old, type 2 diabetes, treated with diet alone. Glycated hemoglobin was terrible, 10%. Metformin, family history of diabetes, an unemployed taxi driver, smokes, but no alcohol. And I had not seen him, I did not know this guy. He was admitted under our surgeons with severe pain and swelling in the right heel. Generally unwell, but there's no history of any injury. And his GP had given antibiotics with no effect. A month ago, he'd had a similar swelling, not as severe, and had discharged a white pus-like discharge, so he told us. Pain resolved. So he was a high BMI. I don't know what the height is in feet and inches, in probably 1.6, something like that, meters, apyrexial. Unremarkable systematic, but his right heel was erythematous, tender, a fluctuant swelling with necrotic skin overlying. I hadn't seen him at this point, so the surgeon said, we'll take him to the OR, the operating theatre, and did an incision and drainage. Purulent material was drained, necrotic overlying skin was debrided, loculi were broken down, a cavity was curetted. This was followed by a saline washout and packing and intravenous antibiotics. This is the surgical approach. The post-operative period. Culture of sensitivity grew Staphylococcus aureus, so he was given appropriately flucloxacillin. Abscess cavity was still discharging thick whitish secretions, and he developed multiple whitish nodular swellings over both plantar surfaces. This was the picture taken by the surgeons. It's not very good, I apologize for that. This was on the unit, and you can see this, I can't get this pointer to work properly, but you can see this cavity here that was following incision and drainage. And you can see there. But also he had one or two small pustules like this white one here. And you see these pustules here, here. You can see these white small pustular lesions. Well, looking back, when we were asked to see him at this stage, so we took a history. He had been admitted with severe pain in his left knee in 2008, tender erythematous swollen knee, diagnosis of septic arthritis had been made. Straw-coloured fluid was drained, no organisms, no growth, so that was wrong. His fluid was sent to my colleague, and he found negatively by refringent crystals. So diagnosis then was acute gout. Treated with colchicine, discharged, no acute attacks since. And he'd been referred to the rheumatologist. When we first saw him, his glucose was 10.8, which is 198 milligrams percent, CRP 33, creatinine, that's about 1 milligram if you're a milligrams normal, thyroid normal, cholesterol elevated, urate high. We increased his metformin, but then he still had this large grade 2B, University of Texas. 2 is deeper than skin only, down penetrating to tendons but not bone. B suggests infection but no ischemia. He had prominent metatarsal heads, but he had normal sensation. Pulses were palpable. And you see here in this x-ray of his foot, there's nothing really to worry me about infection, but he had these classic erosions I'm trying to point to here, which would be compatible with gout. And you can see he also has them in the metacarpals. The heel x-ray was normal. No suggestions of osteomyelitis. And you can see here no evidence at all on the calcaneum of osteomyelitis. And this very useful calcaneal view, which I recommend if you're looking for osteomyelitis in the heel, normal. Look at his finger. These are gouty tophi. And his ear. So I thought this was a foot ulcer secondary to tophaceous gout. He was treated continue because we had staphylococcus. We continued with antibiotics, debridement as necessary, cleaning, and then we did a swab for CNS, a punch biopsy and crystal analysis. And the histopathology showed it was compatible with it, suspicious of a gouty tophus. So gout, of course, is common, but there's hardly any reports of it causing foot ulcers. Has anybody seen gout causing a foot ulcer? No. I'm not going to go into this because you don't want to lecture on gout. But this is just So in him, suggesting that this was actually gout and not was the absence of history of diabetic foot disease, the absence of neuropathy, the absence of peripheral vascular disease, and a strong history of gout with tophi, gouty tophi, tophaceous gout, and the chalky white tissue which was discharging from the ulcer and a raised serum urate. And the biopsy was characteristic of the reaction. So he wasn't the fittest of people. He was markedly overweight, type 2 diabetes. So generalized lifestyle modification, good glycemic control, urate lowering therapy, and we put him onto high dose allopurinol, and the gouty tophi resolved, and he's had no further problems. So that's what we did with him. Now here's any questions about that. Gout you can have many different features presenting as a diabetic foot ulcer, and one not to be caught out on is melanoma. We've reported 2 cases of malignant melanoma presenting just like a neuropathic foot ulcer, but with a lot of callus formation. Any suspicion, do a biopsy and send it to the pathologist. And sometimes squamous cell carcinoma can present as a neuropathic foot ulcer. So there are things to be caught out on. This is an interesting chap. Cases from my diabetic foot clinic, a 52-year-old man with type 1 diabetes for 28 years, painless diabetic neuropathy, retinopathy, proteinuria, but his glomerular filtration rate was normal. This patient had Christmas disease, or hemophilia due to factor 9 deficiency. And he also had a factor 9 inhibitor and previous hepatitis C. In 2002, because of his diabetic neuropathy, he developed a left Charcot ankle. And then a few years ago, he presented with swelling but no discomfort of the right foot. On examination, he had a dense peripheral neuropathy, vibration using the bioanesthesiometer. He couldn't feel anything off scale. If you want to have a look at the vibratip, by the way, I can pass it around. You just squeeze this and you can feel it. Do you want to pass this round? It's a useful way to diagnose neuropathy in the clinic. So, his left foot, and the best way to diagnose an acute Charcot, anybody with neuropathy that presents with a unilateral hot swollen foot, it's a Charcot foot until proven otherwise. That's the most important thing to remember. A hot unilateral swollen foot in someone with diabetic neuropathy treated as a Charcot. So we thought this was an acute Charcot. Look at the temperature differential. We have skin temperature thermometers we use to monitor Charcot foot. And you see there the swollen right foot, the old left Charcot, swelling, loss of sensation, heat. Now the interesting thing was, this is his x-ray before. Now because this chap had haemophilia, I can't remember if it's A or B, but factor IX deficiency, as you know, patients with clotting disorders tend to have bleeds into large joints. And he had multiple bleeds into his ankles. So already, when he was relatively young, you can see there are signs of osteoarthritis in this tibio-talar joint here, with loss of joint space and some sclerosis, and a few osteophytes you can see here. So this gentleman, before his Charcot, had signs of chronic osteoarthritis. And in a young man, this is usually due to haemophilia and recurrent bleeds in the ankle. But then, this was the picture after the diagnosis of the Charcot. He had been walking on this, and you can see this marked disruption of the tibio-talar joint with fractures, new bone formation, and basically destruction. The superficial part of the talus is destroyed. So this is a classic Charcot change. So being slightly cruel, we put this into a radiologist's exam. How can you put this together? Here's someone in his 40s had osteoarthritis in the ankle, then 10 years later he presents like this. And nobody got the correct diagnosis. Nobody, not any radiologist. And you can see later the marked disruption. The talus is almost completely destroyed, and eventually this chap underwent surgery. And you can see this gross Charcot at the ankle. The Charcot at the ankle is very difficult to treat. So he was offloaded with an air cast boot, but there are dangers of TCC, as I said, and after a few days something didn't feel right, so we took it off, and he developed a lesion under the plaster here. So the best cast can cause problems. So he was eventually, it settled down, and it cost because he has to have factor IX plus factor IX antibodies against factor IX, whatever, I can't remember. Anyway, it cost a hell of a lot of money. His cost in hospital was about £250,000 just for the factor IX and the inhibitor blockers. And then he had corrective surgery, had a nail put up through the calcaneum into the talus, and now he's back to walking. So that's a typical Charcot foot, but in an atypical patient because he also had Christmas disease and had already arthritic changes. So it caught out all our radiological colleagues, which is nice to tease them. Here's another case that presented. And this is a 39-year-old white male not known to have diabetes. In 2010, he went onto a diet and fitness regime. And in December of that year, he injured his left foot at home. He trod on some glass, so he treated it with a local antiseptic. Then he presented on the 14th of January 2011 to the walk-in centre with a left foot infection, and his blood sugar was found out to be 18 or around 340 milligrams %. So this was a foot ulcer as a presentation of type 2 diabetes, and I've recently seen another one. So you probably see that too. Because patients present late, they've had asymptomatic diabetes for many years, they've got nerve damage and loss of sensation. So he presented to the walk-in centre, and he was seen in the diabetic foot clinic the week later. They should have sent him the same day, but they waited a week. His neuropathy disability score was 7 out of 10 maximum, so that's marked neuropathy vibration perception in the abnormal range. And he had infected right first metatarsophalangeal hallux ulcer and a sausage-shaped hallux. So if you get this gross sausage dissension of the hallux, this is a good sign of underlying osteomyelitis. And that was first presented, I remember, because I chaired the session at the British Diabetic Association meeting in Harrogate, probably nearly 20 years ago, when one of my juniors presented this case. And sausage-shaped toe, a clinical sign of osteomyelitis. Unfortunately, I didn't have a slide of it before, but you can see in this X-ray quite marked disruption here at the MTP joint, osteomyelitis, and with the septic arthritis there as well. So you can see those changes. Sausage show is a good sign of likely underlying osteomyelitis. And you can see it again there, quite marked disruption of the MTP joint, the proximal phalanx and the distal part of the first metatarsal here. So we admitted him. The MRI is the Manchester Royal Infirmary and not the magnetic resonance. That's our hospital, and he had a first ray amputation. His diabetes was controlled on diet and metformin. And I said to the fellow, I said, let's look in his eyes, because there was a series of cases reported in the Lancet called the foot-eye syndrome. Patients who present with neglect of their feet when they have diabetes, not known to them. You find the diagnosis, and you look in the eyes, and they've got maculopathy. Quite marked macular changes. And this chap had just that. He had marked retinopathy with maculopathy and required laser treatment. Normal renal function. So I referred him to the retinopathy clinic. That was treated. And it was Howell Walsh from Cork in Ireland that reported this in 1975, a series of cases, patients presenting with diabetic neuropathy, a foot ulcer, and found to have eye disease as well. And that was him post-op, and that healed up. First ray excision. Granulating nicely, and he went on his way. Osteomyelitis, as I said, recurrent x-rays are needed. You can't see it on the first, but the second one, you're beginning to see it here. Multiple x-rays will show it. This is osteomyelitis in the toe here, in the distal and intermediate phalanx. Now this kind of osteomyelitis can respond to antibiotics alone, and there was a randomized controlled trial published last year from Spain showing if you randomize patients with osteomyelitis like this to appropriate antibiotics for 6 to 12 weeks or to local surgery, the outcome's the same in both groups. So antibiotics alone can be used if there's a good circulation. And here is progression of Charcot. Just look at this here, 3 x-rays from the same patient. The clue here is the Lisfranc ligament is disrupted. And you see this widening between the first and the second metatarsals, and that's a very early sign suggestive of osteoarthritis at the commonest point, the Lisfranc joint, the midfoot, cuneiform metatarsal joints. And you see the development here to this one here, and then to marked change here. And I have to say, this wasn't treated by us. This was a series of x-rays that were sent in. And if we'd have casted the patient then, if he had been referred on the left-hand picture, we may have prevented the ongoing changes that occurred to this cuneiform metatarsal Charcot joint. We also see spontaneous fractures in diabetic neuropathy. And we published a paper with Peter Kavanagh, who was doing a sabbatical with me many years ago, looking at neuropathic feet and how common undiagnosed fractures were and how common Charcot changes were that had been missed. And here is, we've seen a few of these recently, and they're very difficult to treat. Spontaneous fracture right through the navicular bone here. And these are very difficult to treat. And I don't think we know exactly how to treat them because there are no studies to guide us. So I'll end with this quote from Karl Marx. Centuries scientists have attempted to describe the world. What matters is how to change it. So I'll stop there because it's time to switch to the second workshop. But if there's any other questions, I've shown you a few unusual cases. We've discussed offloading. Offloading is the key to healing neuropathic foot ulcers, plantar ones. And if we offloaded early, they would do well. That's what I would say. Any questions? Can we switch that light off? I can't see at the back at all. That camera light is really... Any questions? Yeah. The microphone? Oh, there's one there. I don't know if it's switched on. You have to switch it on at the side. Yep.
Okay. My question is, I see many cases with osteomyelitis in my clinic, and my question is when to stop antibiotic therapy? Is it upon clinical remission or
very good
radiological
question.
remission?
Until recently, I wouldn't have been able to answer that question with any accuracy. But the study from Spain, which was published by Lazaro Martinez, if I remember correctly, I know the guy, but a complicated name, et al., showed that you could get away with 8 weeks antibiotics or surgery. But subsequent to that, there was a nice paper by Professor Henrique Sanville from Lille in France. And they randomized patients to 6 weeks or 12 weeks of antibiotics and showed no difference. So 6 weeks may be enough. You know, and the key thing is after 6 weeks, if the ulcer's healed, treat the patient, not the x-ray. That's what I say, treat the patient, not the x-ray. So 6 weeks may be enough. That's all I can tell you. Maybe. Yeah, microphone. Can we get the microphone on?
We have a diabetes conference called Egypt 2 weeks ago, and they show us a system that you will measure the temperature of your skin. You put your bare foot and your hands on the dipoles of the system, and it will calibrate the heat exchange of the skin that will refer to the neuropathy. That's one. That's one. The second thing I wrote about, they use the mechanism of Elizarov in elongating bone.
Oh, Elizarov frame.
Yes, in treating the deformity that will happen in the diabetic foot.
Yeah,
Just
I mean,
enlighten us.
some people do use external rotation, external fixation rather, in treatment. Elizarov frame, of course, Elizarov, a famous Russian orthopedic surgeon from Siberia, can be helpful, but some people don't like to use that so much because there's a risk with all these spokes going in, increased risk of infection. And some of my surgical colleagues use internal fixation with a nail or a screw. And I don't think there'll ever be a trial to show which is better, is my honest opinion. I don't think we'll ever know, because they're very difficult to do trials, because A, they're not very common, these severe Charcots, especially at the ankle, that need such surgery, and B, I don't know who's going to be brave enough to do a randomized trial.
What's your opinion about this set that we...
Well, I'm not sure exactly what you refer to. I mean, is it looking at blood flow or heat?
The heat in the skin.
Well, the heat in the skin, of course, there are abnormalities. The autonomic neuropathy can lead to abnormalities of the some of the reflexes of small blood vessels in the skin. So that is certainly important. What are you going to do, right? Has they all seen this vibratip? Yeah. I honestly don't know, because I'm not sure exactly what you're referring to.
It's a set that you will put your barefoot, you will put your barefoot
Yeah.
on the one foot. The other foot, you will put your hands on it. And then make a...
Temperature?
Yes.
Oh, yeah. Well, we use those.
You will have a chart that will have the different colors that will produce...
Okay, I'm with you. So it's a thermogram, really, a thermogram. Yeah, okay. These are helpful, as I suggested. And it might be helpful because if one foot's warmer than the other, that suggests pre-ulcerative lesion. And that's what I was suggesting in my lecture, that this bath mat study, which is similar, this gives you a thermogram, and if one foot's warmer than the other, and they didn't know whether, because this was the first try, and that was predictive of breakdown.
But in my belief, there's nothing but the ocular test that you use.
No, we use skin temperature thermometry, the same thing. And this is a new way of doing it. So yes, that was probably from Podimetrics in the USA, I guess. I know the people, yeah.
Please,
Yeah.
for the diabetic control in a patient with diabetic foot ulcer and infection, First, do we need to stop metformin to avoid lactic acidosis? And the second, yeah, can we give oral, or it's a must to give insulin?
No,
till
I
healing?
think there is no evidence whatsoever that insulin is any better than oral hypoglycemics. It's the level of control you achieve. And we know that neutrophil function is subnormal in hypoglycemia. So that's very important for wound management, wound healing, and infection management. But that's all we know. We don't know that insulin is any better. And it's like patients that, when I trained in neurology too, and neurologists will send me a patient, that this patient has painful neuropathy, put them on insulin. I write back, say, well, had you checked the glycated hemoglobin, you'll realize it was quite normal, and insulin will not do anything more than the current medications will. So there's no evidence at all in this area that insulin does anything. Topical insulin may have growth factors, and there is a suggestion that that may be useful, but it's only anecdotal. There are case reports of topical insulin being absorbed and causing hypoglycemia from a foot wound. So there's no evidence at all that it's achieving good control that matters, not how you achieve it.
What about metformin?
Metformin, I think you can use perfectly safely. I think, my first diabetic clinic was 40 years ago. And I've worked in the States. When I worked in the States as a young assistant professor with black hair in 1983, they didn't have metformin there. So I sent patients to the Bahamas to get it from Miami. It's a good drug. And I think, I've been doing diabetes clinics for 40 years. I've never seen a case of lactic acidosis. And I think it's overestimated. And I think that the evidence for lactic acidosis, metformin, especially in renal dysfunction, is from an expert committee, it's not from any data. I think we can safely use, and even the FDA now have moved to say you can safely use metformin at lower levels of GFR than previously thought. So I think the metformin's a damn good drug, and it's used widely. The Americans even use it widely, so it must be okay.
Thank you.
I think it's... we've only got half an hour left. I think you're supposed to go to another workshop, I think. Oh, you all want to stay here? Gosh. I can give you, if you want to know about the connection between leprosy and diabetes and how neuropathic foot ulcers were discovered, I can tell you that. It's a fascinating story. Okay, we'll go on to another. Let me just see here. Now, I mentioned to you Dr. Paul Brand. And it was thanks to Paul Brand and his work that we know that neuropathy is a major cause of foot problems. And it was he that I mentioned that talked about the gift of pain. Pain is the gift that nobody wants. He worked as a surgeon and a missionary, and he worked in leprosy and diabetes. And he took the diabetic foot from art to science, and I'll show you how. So Brand, who I was fortunate to meet on several occasions and lecture with him, he was born in the beginning of the First World War near Madras in Tamil Nadu, or now Chennai, in India. His parents were missionaries. He was sent back to boarding school for education in the UK, higher education, and then he went to medical school at University College Hospital. And during the Second World War in London, he was a junior doctor in some of the major teaching hospitals. At Great Ormond Street, he was a senior surgical assistant during the war. And it was during the war he saw all sorts of terrible injuries caused by bombs and guns to hands and feet. And he developed surgical techniques to do tendon transfers and correct these things. Then he was invited by the leprologist, Dr. Robert Cochrane, to Vellore, the Christian Medical Center in Vellore in Tamil Nadu. And he arrived there and saw, to his horror, patients with leprosy sitting outside the hospital gates begging with bleeding wounds in their hands and feet. And he asked, why is this? And they said, well, leprosy is a curse from God. These patients, we can't do anything for them because they go to bed. They go to bed and wake up the next morning with new bleeding wounds on their feet. So it's nothing to do with man, it's God. Well, nothing can be done, it's just leprosy. And of course, leprosy is caused by Mycobacterium leprae. It's a very difficult disease to acquire, and the leprosy bacillus likes the cold area, so it settles in the skin, in the hands and the legs. It destroys nerves. But that wasn't known then. So Brand saw these sites. This is in the 50s. I saw these sites in 1980s when I went to the leprosy center at Carigiri that he set up near Vellore. Young people with leprosy damaged their feet and hands. And you see here in the bullock cart, barefoot here, and foot ulcers caused by just leaving your foot in the sun. So nothing could be done. And Brand said, I don't believe this. I think that it's not the infection that causes these lesions. I think these patients have nerve damage caused by the infection. So nobody believed him. So he said, I'm going to do a study. I built my own hospital, which is still there in Carigiri, and he put the young men with leprosy to bed. And to his horror, the next morning, some woke up with new bleeding sores. So remarkably for a surgeon, he thought, well, I'm going to do a randomized trial. I'm going to randomize half the men to go to bed at night, and the other half are going to sit and watch to see what happens. And the clue came in halfway through the night, when through a hole in the wall, out came some rats. And the rats came up to the feet, no feeling, so they began to eat the feet. That was the cause. That's how Paul Brand described that leprosy causes these lesions, not because of the infection, but because of nerve damage. So he solved this by buying a male and a female cat. And they bred many cats, and there were no more new foot ulcers. And that's how it was described by Dr. Paul Brand, that leprosy damages the nerves, and it's that causes the lesions because they're open to trauma, and this was trauma by rats. So leprosy, and you're probably familiar, in the Old Testament of the Bible, there's all sorts of stories about people with leprosy need to be sent to colonies because they're so infectious. It's absolutely untrue. I visited the leprosy centers in Vellore, in Bangalore, in Agra, and these patients have been living with their spouses for years, and the spouses never got leprosy. It's very difficult to catch leprosy. So leprosy, it depends on your immune status, just as tuberculosis, and it destroys the peripheral nerves because it sits in the cold areas, and these patients get what diabetic patients get. But diabetic patients get it in the lower limbs because of length-dependent neuropathy, whereas leprosy is equally in the upper and lower limbs. And all the scarring and deformity of leprosy, don't put that light on, please. All the scarring and deformity of leprosy is caused by nerve damage leading to insensitive injury, just as we see in diabetes. And here's a case I saw with Dr. Aasd. Do you know Dr. Aasd from Dar es Salaam? A good friend and colleague. This is a rat bite from one of his patients sleeping in a hut. The rats have a nice meal because the patient doesn't feel it, and they have an ulcer the next morning. That's exactly what was described in leprosy. So in the 50s, Brand published new surgical techniques for insensitive limbs. He was a Hunterian professor of the Royal College of Surgeons. Then he was president of the International Leprosy Commission. He was awarded commander of the British Empire by the Queen, and he then went to lead the Leprosy Research Center in Louisiana in the United States. Now this is a very historic picture, and there's some well-known people on this slide. This is the Dr. William Wagner, not the composer. Wagner was the one, an orthopedic surgeon in Los Angeles, who described the classification system, the Wagner classification. This is Roger Pecoraro next to him, who sadly died of cancer, but he did the pathways to amputation and a diabetic limb. Lee Sanders, Marv Levin, who recently died, aged 96. Marv Levin wrote the first big textbook, Levin and O'Neill, on the diabetic foot in the USA. This is Larry Harkless. Have you heard of Larry Harkless? He's a true character, but that's the slide after. A true character who is probably the grandfather of podiatry in the United States. Now Gail Reiber in the blue dress, seems to want to move on its own. And that's Dr. Paul Brand next to Gail Reiber. And the person to the left is me 35 years ago. It shows the dangers of working in the diabetic foot. And this is the diabetic leprosy center and the diabetic foot center in Carville, Louisiana, that Brand set up. Beautiful colonial style near the Mississippi River. and this is Karigiri in India, the hospital he set up for patients with insensitive feet, mainly diabetes now. And there's Dr. Paul Brand with David Armstrong and myself when he was introducing me at a big lecture in Seattle in 2002. So his contributions to leprosy and to the diabetic foot are offloading, surgical reconstruction, and experimental leprosy. He said, it's interesting because in America they see indigenous leprosy in the southern states, Texas, Louisiana, Mississippi. And there's a lot of armadillos. And the armadillo is the only animal you can culture leprosy bacillus in the foot pad. He was correct. He said the armadillo is responsible. Then in 2011, you're still seeing new cases, but then a paper was published that year, the genome sequence of Mycobacterium leprosy identical in man and armadillos. So Paul Brandon suggested this, and 40 years later it was proven. But clinical observation was his best observation and contribution to diabetic foot care. Any patient that comes into your clinic with diabetes and they've got a foot ulcer on the plantar surface and they walk in without limping must have neuropathy. They must have it, otherwise you'd be limping because it would be uncomfortable. And that's his observation. And I've told you that one. This is a patient, he quoted, I shall never be free until I can feel pain. And even the famous writer William Faulkner wrote these words, if I were to choose between pain and nothing, I would choose pain, because pain protects us from injury. This is another case I could tell you about. This is a case that came to me, I think it was when I just moved to Manchester about 30 years ago. And I was asked to see this patient, type 2 diabetes. I looked at his legs, I said, these look like symmetrical burns. I said, tell me what happened here. He said, oh, I'll tell you. And he was a patient of Moroccan origins, early onset type 2 diabetes, a real character. And he said, well, a few years ago I went to my GP because I had some tingling and strange feelings in my feet. They were on fire, they're burning. And his GP said, oh, you've got diabetes, you must have peripheral vascular disease. Did not examine his feet and put him on a vasodilator, which don't work anyway. So a month later, the symptoms were the same. So he said, don't believe in this medicine. So we went to an alternative medicine Chinese practitioner in Chinatown in Manchester that practiced the technique of moxibustion. Have you heard of this? This is like acupuncture, but you apply a burning incense stick to the skin. And when it's too painful, you hold it back at that level, and it's supposed to improve circulation, the meridians. So, of course, this chap had no vascular disease at all, but he had no sensation. So he couldn't feel the incense sticks, and they provided these burns for him. So that's clinical observation. Very important. So the art was what Paul Brand said. He was lecturing to the American College of Physicians in about 1986. And they asked him, Dr. Brand, what's the most important step we can do to reduce amputations in diabetes? And being in America, they thought some new scanning technique, MR or something, and he said, the most important thing you can do is remove the patient's shoes and socks every time you see someone with diabetes and look at the feet. And he's absolutely right. I've shown you this one. I've shown you this one. This is our Northwest Diabetes Foot Care study. We published 15 years ago a study in the National Health Service. We can do population-based study of 16,000 patients. The first study was on a smaller number of 10,000 or so patients. And what we showed using 3 sensory modalities. This is the neuropathy disability score. It's very easy. If you can't feel vibration in the toe, you score 1. If you can't feel pinprick, 1. If you can't feel hot, cold, you score 1. If you're absent reflex, that's 2. So it's 5 per foot, maximum 10. And what we showed here, following patients for 2 years, 291 patients out of the 9,000 developed ulcers, more common in males, that's what we see in the UK, I suspect not here. Are ulcers equal between males and females here? You don't know. It's more common in males in Western countries. And the best predictor was that simple neuropathy disability score. So a simple score can predict risk of ulcers. And he did all the work on pressure relief. Back in 1963, he showed the importance of relieving pressures and loads from the diabetic foot. And I've shown you that. In the PodaTrack, I've shown you this. This is all his work. And offloading pressure, I'm not going to go through all that. And he showed all this. that he said what you should do is put patient in a cast, because the early studies in leprosy are from Sri Lanka, Ceylon, and India in the 1950s and 40s, before antibiotics. They said if you've got a nasty neuropathic foot ulcer, just let it stew in its own juices. In other words, put it in a cast, don't worry about infection because we can't do anything, and they got better. So this is how it was shown. So Brand did a lot. What else have I got here? And he did this study of infrared thermography, as I mentioned in my talk, and showed that the foot heats up before it breaks down. And this was the study that Lavery did to confirm that. So you can use a skin temperature thermometer, and you can do. So there has been a lot of progress in the diabetic foot over the years. We've got the international consensus, which I know is translated into Arabic. And the seventh meeting was held in 2015 in Den Haag, or The Hague in the Netherlands, on the diabetic foot. The next one will be 2019. The diabetic foot is no longer the Cinderella of diabetic complications. If you look at over the years, the percentage of papers on the diabetic foot on PubMed as a proportion of the total papers on diabetes, it's increased from 0.7% in 1988 to 6.5%. So there's been a huge increased interest in the diabetic foot, and I hope this will have some effect. But this is what I like about Brand. When he retired, he said, because of where I practiced medicine, I never made much money. But when I look back over a lifetime of surgery, the host of patients, friends who were once my patients, bring me more joy than wealth ever could. So he was a true physician of the people, a surgeon. He worked, he saved a lot. And at his retirement due, I can tell you what he said. If I come back in the next life, I think I will become a shoemaker and not a surgeon, because more patients have congratulated me on the shoes that I've given them than on the surgery that I have done. So he was a great character, and it's thanks to him he's sort of helped us a lot in the diabetic foot area. Now it's 7:15, so we've got time for any more discussion if you would like. If you want to ask anything about the diabetic foot or anything about diabetes, I'll do my best. Any questions? Or you've had enough? Yes, a question at the back. Have we got a microphone? Or you can always shout. A microphone is on its way.
Regarding metformin in people, in diabetic patients who will take contrast to do angiography or angioplasty, should we stop it 48 hours before and after, or what?
Sorry, it's not easy to hear. Have you got another microphone?
على صوت شوي.
So the question is about angioplasty.
Regarding metformin use,
Or metformin?
should we stop it?
Okay, I think we do tend to stop metformin before angioplasty. I think we need to be careful because, as you know, there can be worsening of renal function, but I suspect we probably don't. But I think because it's in the guidelines, we're going to stick to it. I honestly think that metformin is probably a pretty safe drug in such a situation. We probably don't need to stop. But guidelines suggest that we do. So, you know, if you're like in America in a litigious society, and the attorney will say, "Oh gosh, they gave him metformin, let's sue." That's the worry. But the evidence is minimal.
Can I ask another question?
Sure.
Regarding alpha lipoic acid. Alpha
Lipoic acid, yes.
Is it
Yeah.
is it unique to our country, or
The antioxidant alpha lipoic acid or thiotic acid. There are good studies from my very good friend Dan Ziegler in Dusseldorf where it is available. It's not available in my countries where I work in the UK or the USA. So I'm probably not the best person to comment, but I know that there's been a meta-analysis that shows that alpha lipoic acid is particularly helpful in pain relief in painful neuropathy. So it may have a place, and there are data to support its use. And there is a meta-analysis, which is more than can be said for many other treatments that are still used in diabetic neuropathy. So I think it does have a place, but you know, I haven't had the opportunity to try it on my patients because it's not licensed in my country.
Oh, thank you, sir.
You're welcome. Yeah, over here.
If I examine patient and I found that sensation is diminished and vascularity is intact, peripheral vascularity
Impaired?
intact vascularity, intact peripheral pulsation, but sensation is diminished. The next step, there is no ulceration, there is no callus. The next step, what? Control.
I think that there are different levels of risk. Now, this would be, in America they call it LOPS, loss of protective sensation. And our guidelines, and Armstrong and I co-chaired the American Diabetes Association guidelines on this, were published 9 years ago, are that these patients require regular foot care because they're at risk of insensate injury to the foot. So they've got loss of protective sensation with a normal vasculature. They are reassured because they don't feel any pain, and they're reassured they are at risk, and we showed their risk of getting a new ulcer. First ulcer each year is 7-fold, and if you've already had an ulcer, you've got a 30 to 50% recurrent risk. But you're talking about patients with no ulcer history, normal vasculature, but impaired sensation. These patients, what we tend to do, they have an education session from our nurses, and they have regular podiatry, perhaps at least 4 times a year. That's probably what they need. Now, here you don't have formal podiatry, but you do have foot care specialists and assistants, I think. I know from people that have been to me from Alexandria and elsewhere that this is the case. And you do have good foot clinics, because some of you here run them, I know. So it is available, and there are things you can do. I can't prove to you that that's going to reduce the incidence of first ulcers, but a multidisciplinary approach, education, regular podiatry, good footwear, probably will, and that is shown. Probably. Any other questions? Yeah, here. Oh, one there. Yeah, please. No, you're there. Yeah.
Okay. Thank you, first of all. And please, I would like to ask you on routine clinical practice, do you recommend pseudomotor dysfunction testing for your patients, or just to keep it at the research level? Do you have?
That's a good question. There is, I didn't show you, a test called a NeuroPad, which is a sensor for sweating. And it's basically a chemical reaction. You put this little plaster on the foot. If there's normal sweating, it changes from blue to pink. If there isn't any, it remains blue. So this is a very simple, it's a starch test for sweating. And autonomic neuropathy leads to decreased sweating and increased blood flow. So that can be useful to the patient, because if you put one on them and one on their partner, you know, they say there's something different. Mine didn't change color, hers did. So that might help patients realize that there is something different about them which they cannot feel because they've got no discomfort whatsoever. So that can be used in clinical practice, but any other more complex tests, such as galvanic skin resistance, we've used in research but not in clinical practice. The most important thing is these patients have dry skin, especially in hot climate. You get buildup of callus and ulcers, and regular rehydration using an emollient, cream, intensive care lotion or something twice a day helps replace the sweating and reduces callus formation.
Thank you.
Question here.
What I want to say is that we are in Egypt, and in some countries we're facing a very hot climate in summer. And when we're using a total contact cast as a method of flooding, we see more maceration and more infection. So we prefer to use half shoes or heel wedges better than total contact cast in these cases, or we use it and change it frequently.
Yeah, I think that's a very good point. I mean, hot climate, and I work periodically in Miami where it's not only hot but it's very humid. Now, the good thing about neuropathic feet is that they don't sweat, but higher up the leg can. Under a cast, you may get sweating and a reaction with the cast, an allergic reaction. And I think you're absolutely right. I mean, the removable cast walker, the half shoe, are just as good if they are worn. That's the big if. And what I tend to do, today we start patients in a removable. We make a Scotch cast boot, described originally from Leicester in England. We use the Scotch cast boot and we use that. If it's apparent to us the patient is not wearing it, it comes back, pristine, clean, never been worn. It's been worn when they walked out the clinic, then they're back into their shoes, and they put it on when they come back a week later. And the ulcer's just the same. Then we'll say, we're going to make this irremovable for a week, and the patient looks after a week, gosh, it's nearly healed. Perhaps I should wear it. and then we'll stop making it. So I think you can alternate between removable and irremovable. But you're absolutely right, in a hot climate there are dangers. And we use them in Miami, as I said, where it's hot and humid, and here it's even hotter in the summer, and humid, I guess. Humid, yeah. So there are dangers, and we always remove the cast after 1 week, after 2 weeks, to make sure there's no damage. But sometimes I've got one patient who was sent to save his leg. He's only got one leg left, and we've nearly healed a huge plantar ulcer. But he got a reaction to the cast, so we had to leave it for a week. So we've got to be very careful. We remove it twice a week, if needs be. Any other questions?
After amputation.
Okay, yeah, the care of the foot after amputation. First of all, I would say, and I saw a patient yesterday morning in my clinic, a remarkable guy. He met his wife when they were both on dialysis. She had an SPK, simultaneous pancreas kidney transplant, 15 years ago. She's got normal blood sugars, off dialysis, normal renal function. He had an SPK, but he lost his kidney. Now, if you have a simultaneous pancreas kidney transplant, if I would want to lose, if you're going to lose one, lose the pancreas, because life on dialysis is terrible. But he lost his kidney, and during this time he got a nasty osteomyelitis and a calcaneum with some localized ischemia, and we did bypass. We struggled for ages, and I said eventually, we really need to say, this patient, we've left him too long. There is a place for amputation. So he had an amputation, then he had another kidney transplant, and he walked into my clinic yesterday. He said, "Doc, I left that amputation too late." I said, "We did as well, you're right." And what I want to do is to make a video for someone like him who said, "Look, I had 2 years, I couldn't walk, it was painful, I had osteomyelitis and ischemia, and now I'm on a false leg, I've got a new kidney," and he walked in and a medical student couldn't tell he had an amputation. So I think there is a place for amputation, but the key thing, if you've had an amputation, is to look after the contralateral foot. These patients are at high risk. First of all, the pressures and loads under the foot after an amputation on the other side are very abnormal, and they've got neuropathy. He's already lost one toe, but he's learned to look after his feet because he's got one left. And he's only 50 and he's doing extremely well. Remarkably, I saw another patient with an SPK yesterday, 3, and they're all doing well. So there is a place, and I'll talk tomorrow about chronic kidney disease and dialysis, because you deal with dialysis patients. Life on dialysis is miserable. Patients feel unwell. Foot problems are the commonest problem with dialysis patients is foot ulcers. They've all got neuropathy, they've all got risk factors, as we showed years ago. I'll talk about that tomorrow, because the complications go together. End-stage renal disease plus foot problems is a very bad outlook, as I've already said. So they have monthly podiatry, very regular foot care, and they're all very cautious if you've lost one leg. But he said to me, "You're right." I said, "I'd love you to make a video to tell patients who are struggling on after 2 years, not walking, there is life after amputation." And this guy would say on a video or a film or a DVD, "I should have had my amputation earlier because I'm so much better afterwards." And we showed in a study in the 80s that quality of life of patients post-amputation who are mobilizing is better than those with chronic foot ulcers. Yeah, question at the back. Microphone. Who's got the microphone? Oh.
Excuse me, if I will refer my patient to the ophthalmologist. What are the findings that will be seen in the cornea that will correlate the risk of having the neuropathy?
Yeah, okay, yeah. I'll see if I can find a slide for you. The ophthalmologist does not do that. This is research. And what we've done, we've put corneal, this is a special camera, a corneal confocal microscope. You take a picture and it looks at the Bowman's layer in the cornea and you can see the nerve fibers. So the ophthalmologist does not do that. This is done by ourselves, by my research group. And what we've shown there is that the change is you have reduced nerve fiber density, abnormal nerve fiber length, and you take a number of photographs and measure the nerve fiber density. And as the neuropathy in the leg gets more severe, the nerve fiber density in the cornea goes down. Now I'll probably find you a photograph to show that, but it'll take me a few minutes.
But still in research.
Yeah. Well, what we've done now as another research project to try and put research into clinical practice, we've put 4 corneal confocal microscopes into opticians' shops, because in England, blindness and diabetes, of course, are very common. And diabetes was the commonest cause of blindness in working age adults until 3 years ago. What we've done is we've introduced everybody with diabetes gets a letter once a year, they get optician appointment, a retinal photograph, anything worrying, they're sent straight to the ophthalmologist. So what we've done is, because of this screening program and early treatment, diabetes is no longer the leading cause of blindness. So what we've done in the optician is have a corneal confocal microscope as well, so they have their eyes checked for retinopathy and the nerves can be checked by the corneal confocal microscopy. We're picking up early neuropathy, but that's ongoing. So that's a possibility.
Okay. Thanks.
We have here the ophthalmology museum here and the ophthalmology hospital here. They have, for about 10 years ago, they have this correlation between the cornea and the nephro. They have it, and they have about three or five theses about this. This is a regular diabetes maneuver that will done in Nasser Institute and in the ophthalmology museum here in Cairo. It's a hospital and the yes.
Okay, well that's good. Write it up, publish it.
It's been there about 7 years ago. It's been
Okay, well, it's probably, I'm sure Malik knows about it. I can show you, I'll see if I can find 1 or 2 photographs of corneal confocal microscopy. Where's my stick? I should be able to find you somewhere a picture of neuropathy. No, not that one. By the way, that's diabetic amyotrophy. Do you see much diabetic amyotrophy, proximal motor neuropathy? Marked muscle wasting, neuropathic pain in the thighs. We see that occasionally. Proximal motor neuropathy. Amyotrophy, yeah. Anyway, I'm trying to find you a photograph of... and it's not there. Okay. Yeah. I may not find one, but let me just see. There's a chance I might find it here. No. Can't remember what I talked about there. I can't find this. I wasn't expecting to have to talk about corneal confocal microscopy. I can't find a talk on it. I tell you what, I'll look tonight, and if I can find a talk on it, I'll put it in my nephropathy lecture tomorrow. Because I have got slides of it. I fear I'm not going to be successful. I'm going to hold. Oh, hang on a minute. I might have something here. My Banting lecture. Right, I think it's in here. This is the Banting lecture I gave for Diabetes UK this year, and I did show slides of corneal confocal microscopy. Do you see any necrobiosis? Necrobiosis lipoidica diabeticorum? Yeah. We did the seminal study on it years ago. Ah, here we are. Corneal confocal microscopy. Okay. Right, here's the corneal confocal microscope. And as you know, corneal innervation, I'm sure you remember from your neurology days, comes from the ophthalmic division, 6th division of the 5th nerve. It resembles a spinal root, so that's why we use it. That's what a control scan looks like, okay? That's what the corneal, you see here, fibers, and the black shows the nerve fibers, and the green shows branching. So you see branching, then you can measure nerve fiber density. That's a control. The next one comes from someone with severe diabetic neuropathy. Not that one, that's just the branches. You see how different that is? That's severe distal symmetrical polyneuropathy in the cornea. You see one fiber, so decreased fiber density, and if you eye of faith, you can see one branch. So what we showed in this first paper published 14 years ago was the corneal confocal microscopy, and you see here on the bottom there, the top is the left is the normal non-diabetic or diabetic with no neuropathy, on the right is the severe, and the severity of neuropathy from control, mild, moderate, severe on each of those boxes, looking at nerve fiber density, nerve fiber length, and tortuosity. So you can see how it correlates, and that's what we showed. And then we showed it detects early change after pancreas renal transplantation. I'm not going to go through all that. And that was the group. So there you are. That's what it looks like. And that's the group. There's Riaz Malik, you probably know, top left, and myself top right, and some of the people doing the work. And Didio, what do you call him? Not Maurizio, Rahilic from Croatia was talking about blood glucose flux. Many years ago we showed that blood glucose flux, actually unstable blood sugar control leads to neuropathic pain, probably because of increased biochemical changes that leads to firing of neuroma-like structures in diabetic neuropathy. And we showed if you stabilize blood sugars in a very early study of continuous subcutaneous insulin infusion, you reduce neuropathic pain. So it's a flux from high to low. And I first found that out because when I was my early diabetic clinics, we started with glucose in the urine monitoring. Just in the early days of regular blood glucose monitoring, I asked one patient, what about your blood sugars? He said, I don't need to do them. I've got bad neuropathy, and if my blood sugar is too high or too low, the pain is worse. Then I check it. So that led me to this study where we looked at continuous glucose monitoring. And in the old days, this was 15 years ago, and there's someone with pain-less neuropathy, blood glucose flux. 10 is 180 milligrams %, and there's someone with painful neuropathy, much more unstable. And we know that sudden change in glycemic control can make neuropathic pain worse, such as insulin neuritis. And we showed that in the painful group, the overall control was worse, more hypoglycemia. So blood glucose control and stability is what matters in the management of neuropathic pain. So I'll stop there. It's after 7:30. It's a long day. Okay, thank you very much. I think we start at 10 o'clock tomorrow, which is very generous. In America, we start at 7 o'clock, but there we are.